Hello, everyone, and welcome to our module on hypoxemia. So, the term hypoxemia means a decrease in the amount of oxygen in the blood. But in terms of pulmonary medicine and pulmonary physiology, when we say there is hypoxemia present, we mean there's a decrease in the P little AO2. And the P little AO2 is the arterial partial pressure of oxygen. And anytime this value gets low, that means there's defective oxygenation of blood by the lungs. We'll talk about some of the reasons why this can happen later. And there are many reasons why the P little AO2 can become decreased, but we categorize all the different reasons by the AA gradient. And the AA gradient refers to the difference between the partial pressure of oxygen in the alveoli, in other words, the alveolar partial pressure of oxygen, and the arterial oxygen partial pressure, the P little AO2. So the difference between these two numbers is the AA gradient, and that's how we categorize all the different causes of hypoxemia. So to understand the AA gradient, let's take a look at this cartoon I've placed on the slide here, which shows a single alveolus with its associated pulmonary capillary. And blood is flowing into the pulmonary capillary from this direction, coming from the venous side of the body, and going out in this direction, going to the arterial side of the body. So if we're at sea level breathing normal room air, the oxygen content of inspired air is a partial pressure of oxygen of about 150 millimeters of mercury. And that's the air that's going to fill our lungs, including all the alveoli. But if you could measure the oxygen content inside of an alveoli, it would not be 150, it would be lower at about 100. And that's because some of the oxygen in the inspired air is taken up by the blood in the pulmonary capillaries. So a normal P big AO2, a partial pressure of oxygen in the alveoli, is about 100 millimeters of mercury. In terms of blood, on the venous side over here, blood that's coming into the pulmonary capillaries has a partial pressure of oxygen of about 40, and the hemoglobin is about 70% saturated with oxygen. After blood leaves the pulmonary capillaries, however, the oxygen has equilibrated with the oxygen in the alveoli, so the partial pressure of oxygen of blood leaving the pulmonary capillaries is 100. In other words, it's identical to what you have in the alveoli. But when we take samples of arterial blood and we measure the partial pressure of oxygen, we don't get a number like 100. Instead, we get something a little bit lower, normally around 90 millimeters or so, with the oxygen fully saturated. And so this difference between the pressure of 100 for oxygen in the alveoli and the pressure of 90 for oxygen in the arterial blood is called the AA gradient. And the reason it exists, even in patients who are normal and fully healthy, is because there's some venous blood that does not go through the pulmonary capillaries. It can travel through other veins, bypassing the lungs, and then mixing with blood from the pulmonary capillaries in the arterial system. So for this reason, you always get a little bit of dilution of the oxygen that comes out of the pulmonary capillaries by the time blood reaches the arterial system. And that difference between the P little AO2 and the P big AO2 is the AA gradient. So to obtain the AA gradient for a patient, we need two numbers. We need the P big AO2, that's the partial pressure of oxygen in the alveoli, and we need the P little AO2, that's the partial pressure of oxygen in the arterial system. Well, the P little AO2 is fairly easy to get. We obtain an arterial blood gas sample, that's what's shown in this picture here, and we send it to the lab and we can measure the oxygen content of that blood, and that gives us the P little AO2. But how are we going to get the P big AO2? We don't have a way to sample the gas deep within our lungs inside the alveoli. So what we do to get the P big AO2 for calculation of the AA gradient is we use the alveolar gas equation. That's what's shown at the bottom of the slide here, and it will give us a number for P big AO2 so we can calculate the AA gradient. In order to use the alveolar gas equation, we need two numbers. One is the PiO2, that's the inspired oxygen content of the air that we inspire. And we usually know this, so if patients are at sea level breathing room air, then we know the PiO2 is 150, like we said in the last slide. And if patients are on supplemental oxygen or they're not at sea level, we can also calculate their PiO2. So this number is fairly straightforward to obtain. The other number we need for the alveolar gas equation is the P big A CO2. This refers to the carbon dioxide content of air inside the alveoli. And the way we get this number is also from the arterial blood gas sample. So P big AO2, the carbon dioxide content of the alveoli, is equal to P little a CO2, meaning the carbon dioxide content of arterial blood. Remember what I told you on the last slide, the alveoli and the pulmonary capillaries equilibrate, so blood leaving the pulmonary capillaries has the same gas content of that in the alveoli. Unlike oxygen, the carbon dioxide concentration doesn't change much in going from the pulmonary capillaries to the arterial system, So the value we get for P little a CO2 from an arterial blood gas sample is equal to the P big A CO2. And now we have the two numbers we need for this equation at the bottom of the slide here, so we can calculate a P big AO2, and from that we can get an AA gradient. I know this is a lot of stuff to take in, but if you just take a second to think about it, it sort of all makes sense and get it straight in your head, because these are the steps used to calculate the AA gradient. So in this slide, I've summarized all the important points you want to remember about the AA gradient. It's the difference in the partial pressure of oxygen in the alveoli compared to the arterial system, and it's very helpful for evaluating hypoxemia, as we'll see in just a minute in this video. To obtain the AA gradient for a patient, step one is to use an arterial blood gas sample to measure the P little AO2 and the P little a CO2. Once you have these numbers, you can plug them into the alveolar gas equation shown here, and that will give you the P big AO2. And once you have that, you can calculate the AA gradient, which is the difference between the P big AO2 and the P little AO2. And a normal value for the AA gradient in a healthy person with healthy lungs is about 10 to 15 millimeters of mercury. And the reason you always have this gradient present is because of what I said a few slides ago. There is shunting of blood from the right side of the heart to the left side of the heart without going through the pulmonary capillaries past the alveoli. The two important vascular structures that cause this to happen are the Thebesian and bronchial veins. They're not super important vascular structures. You probably haven't heard of them before, but they're responsible for the normal AA gradient because they allow blood to flow past the lungs without going through the alveoli. And so, as I said earlier in this video, the definition of hypoxemia is a low PaO2, P little AO2. So if you look at this equation for AA gradient, in hypoxemia, the P little AO2 is always low. That's the definition of hypoxemia. What the AA gradient is telling us is what's going on with the P big AO2. Is it also low, or is it normal or even increased? And that's really what we want to know from the AA gradient, is how is the change in PaO2, the decrease, which we know we have from hypoxemia, how is it related to the change in P big AO2? A couple more key points about the AA gradient. So normal values for alveolar PO2 are around 100 or a little higher maybe. Normal values for PaCO2 are around 40, and normal values for P little AO2 are around 90 to 100. And so if you look at this alveolar gas equation I've shown on the slide here, for patients at sea level breathing room air, PiO2 is always going to be 150. So in order to get a normal value for P big AO2, the most important factor in this setting is the PaCO2. What's it doing? That's what's going to determine what you get for P big AO2. So if the PaCO2 is low, it's going to make this whole term here smaller, and the P big AO2 is going to go up. And that's what happens when patients are hyperventilating. When patients hyperventilate, they're going to increase the amount of oxygen in the alveoli, that's the PaO2, and they're going to blow off more carbon dioxide. So this term right here is going to go down. Make sure you understand this, that any time the PaCO2 is low, that indicates the patient is hyperventilating, and that's going to give you an increased P big AO2 compared to normal. On the other hand, if the PaCO2 is high, then the opposite is going to occur. That means the patient is hypoventilating. They're not blowing off enough CO2. That's why the PaCO2 is high. And that means their P big AO2 is going to be low. So many times in board questions, they won't give you all the numbers to use the alveolar gas equation, but they will tell you what the PaCO2 is, and that's what's critical. If they tell you that that's low, then you know the patient is hyperventilating and that this equation right here is going to give you a higher value for P big AO2. If they tell you the PaCO2 is high, then the opposite is happening. Take a second to get your mind around this, and trust me, it will help you answer many pulmonary physiology questions. So now that we've gone through all that, we can talk about how to use the AA gradient to determine the cause of hypoxemia for a patient. And so first we'll talk about hypoxemia when it occurs in the setting of a normal AA gradient. Anytime you see a normal AA gradient with hypoxemia, it means there is a low alveolar oxygen content, a P big AO2. If you look at this equation at the bottom of the screen for the AA gradient, in hypoxemia, the P little AO2 is always decreased. So if you're going to keep this difference between the P little a and the P big A the same at a normal AA gradient of 10 to 15, then this number has to go down too. That's the only way you can keep this gradient, this difference, the same. And that's what's happening in hypoxemia with a normal AA gradient. The alveolar oxygen content is decreasing. And this is a super high yield concept in pulmonary physiology to understand. Well, if you look at the alveolar gas equation, which I've written right here, there are two ways that the P big AO2 can fall. One is if the inspired oxygen content goes down. And the classic cause of this problem is high altitude. So when you ascend to a very high altitude, there is decreased oxygen content in the air because atmospheric pressure is lower. So for example, we've already discussed that the PiO2 for a person breathing room air at sea level is about 150. The PiO2 at high altitudes that you can find in the United States can be as low as 100 or so. And so when this happens, the P big IO2 is going to go down, and that's going to reduce the P big AO2, causing a normal AA gradient to go along with hypoxemia. In the setting of high altitude, however, you should keep in mind that the PaCO2 is going to be normal. PaCO2 depends entirely on your ventilation rate. If you are ventilating your lungs normally, the PaCO2 will be normal, and at high altitude, patients can ventilate their lungs normally, so there's no change in PaCO2. The other way you can develop hypoxemia with a normal AA gradient and see a fall in the P big ACO2 is if the PaCO2 goes up. When that goes up, it's going to make this whole term bigger, and that's going to reduce the P big AO2. So what makes the PaCO2 go up? Well, that's what happens when you hypoventilate the lungs. You don't blow off enough CO2. So this happens if there's a reduced respiratory rate or a reduced tidal volume or both. Either of these things or both can result in hypoventilation. That's going to cause less CO2 to go out with expired air, so there's going to be an increase in the alveolar CO2 content, and in turn that will lower the P big AO2 by this equation right here. And so the result is that because of the reduction in P big AO2, P little AO2 becomes reduced, but there is no change in the AA gradient that remains the same. And some of the things that can cause hypoventilation are shown here: narcotic overdose, neuromuscular weakness, obesity, but there are many others. Any cause of hypoventilation can give you hypoxemia with a normal AA gradient. So just to review, because these are important points to understand, in order to have a normal AA gradient, you have to have a fall in the P big AO2. Hopefully that makes sense to you by now. And by this equation shown right here, the alveolar gas equation, there are two ways you can get a fall in the P big AO2. One is if there's low oxygen content of inspired air, and that's what occurs at high altitude. This PiO2 number goes down. The other way you can get a fall in the P big AO2 with a normal AA gradient is if this number goes up. And that's what happens when there's hypoventilation and the CO2 content of alveolar air rises. Anytime there's hypoxemia with a normal AA gradient, the hypoxemia will improve if you give the patient oxygen. And that all makes sense according to the gas equation I've written right here. So remember that P big AO2 depends on the inspired oxygen content. So if you raise this, that's going to raise this number too. And remember that this number is low when there's hypoxemia with a normal AA gradient. Basically, this number is what's causing the decrease in the arterial concentration of oxygen. There's so low oxygen in the alveoli that the arterial blood cannot become fully oxygenated. So if you fix this by administering oxygen, then that will improve the oxygenation in the arterial system, and that will resolve the hypoxemia. Okay, then the other type of hypoxemia, according to the AA gradient, is hypoxemia with a high AA gradient. This means that you have hypoxemia with a normal or increased alveolar oxygen content. So let's look at this equation again on the bottom of the slide. Remember, when there's hypoxemia, P little AO2 is always decreased. What we want to know from the AA gradient is what's happening inside the alveoli. So when there's a high AA gradient, it means the P big AO2 is not decreased. It is either normal or it is increased, and that's what's making this gradient, this difference between these two numbers, larger. Another way to think about this is when you have hypoxemia with a normal AA gradient, the problem is filling the alveoli with oxygen. That's why the PaO2 is down. In these disorders we're going to talk about now, where you have hypoxemia with a high AA gradient, you're actually filling the lungs normally. The problem is that oxygen is not getting from the alveoli over to the arterial side for some reason. And so we'll talk more about this in the next few slides, but most primary lung diseases have a high AA gradient. So patients with pneumonia, patients with pulmonary edema, when they develop hypoxemia, they will always have a high AA gradient. And that's because if you look at this cartoon here, in all these primary lung diseases, you have some barrier between oxygen going from the alveolus to the pulmonary capillary. That means that the alveolar oxygen is going to be normal or even high if you're giving the patient oxygen supplementation. But despite that, the arterial PO2 is going down, and that's what's creating this larger gradient between these two numbers. And there are three basic sort of fundamental mechanisms that create hypoxemia with a high AA gradient. We're going to talk about each of these one at a time in the next few slides. And these three mechanisms are diffusion defects, shunts, and VQ mismatch. So the first mechanism of hypoxemia with a high AA gradient that we'll talk about is diffusion limitation, or some defect in the diffusion of gas. So gases must diffuse from air to blood in order to normally oxygenate the blood and remove carbon dioxide. It's fairly obvious, but this is a point we need to state when we're talking about diffusion. And the rate of diffusion of a gas from the alveoli to the blood or vice versa depends on a couple of things. First of all, it depends on the pressure difference between air and blood. So if the partial pressure of oxygen is the same in the air inside the alveoli as in the blood in the capillary, then there won't be any driving force for diffusion and no gas exchange will occur. We need some partial pressure difference between the air and the blood. The next thing that matters is the area of alveoli for diffusion. One of the reasons we have so many alveoli in our lungs is because that provides more surface area for diffusion. And then the final element is the thickness of the alveolar tissue. So if we have like a millimeter or less of thickness here between the air and the alveoli and the blood, that's one thing. If it were 10 inches thick, for example, which would never really happen, but if it were, that would obviously be a big barrier to diffusion. So with that in mind, shown on this slide is an equation that can be used to calculate the volume of gas per unit time that diffuses across a surface. So it's equal to the area of that surface times d, which is a coefficient related to the surface and the particular gas you're studying, times the pressure difference between the two sides of the surface. We mentioned this before, but you have to have a difference in gas concentration to drive diffusion. And then the denominator of the equation is the thickness of the surface the gas has to diffuse across. So just to make this very clear, let's look at this little cartoon I've put on the slide here. So let's imagine that this P1 represents the partial pressure of oxygen inside the alveoli, and let's imagine that it's 100, which is pretty normal. Over here, let's imagine that P2 is the partial pressure of oxygen in venous blood entering the pulmonary capillaries. That's about 40. So this difference between P1 and P2 of 60 is what's going to drive diffusion. That's this value right here in the equation. The other two variables that are going to affect diffusion are the area, the surface area for absorption of gas. And one of the reasons we have so many alveoli is to increase the surface area for diffusion. And then also the thickness of those layers. So if anything happens to increase the thickness of the alveoli, that's obviously going to become a barrier to diffusion. And because it's in the denominator of this equation, it's going to decrease the volume of gas that's absorbed per unit time. So what are some of the clinical situations where diffusion limitation leads to hypoxemia, meaning a decreased p(a)O2, in the setting of an increased AA gradient, which, as we've already talked about, is always going to come from a normal or an increased p(A)O2. So some of the clinical scenarios where this can happen are, first of all, emphysema. So in emphysema, the surface area of the alveoli falls because alveolar destruction occurs. With a fall in area, according to this equation, there will be less gas diffusion over time. So that's how you can develop hypoxemia with a normal AA gradient in emphysema. And then there are a couple of clinical scenarios where the diffusion distance, meaning the thickness, rises. Two of these are pulmonary fibrosis and pulmonary edema. So in both of these conditions, the thickness over which gas must diffuse increases. In pulmonary fibrosis, it's because of deposition of fibrous tissue. In pulmonary edema, it's because of fluid. But in both cases, thickness goes up, and that's going to make the volume of gas that diffuses go down. So all of these clinical scenarios I've listed here lead to a change in the diffusion ability of gas, in other words, a diffusion defect or limitation, and that in turn leads to hypoxemia. So to understand shunts and VQ mismatch, we have to first review the concept of the ventilation-perfusion ratio, which I talk about in detail in other videos. So the ventilation-perfusion ratio, or the VQ ratio, is the ratio of alveolar ventilation to pulmonary blood flow. And matching of alveolar ventilation to pulmonary blood flow is critical for gas exchange. If you have areas of lung tissue that are underventilated with a low V or underperfused with a low Q, these will both lead to inefficient gas exchange and inefficient oxygenation of the blood. So in shunting, you have areas of the lung where there is no ventilation. This leads to an extreme reduction in the VQ ratio such that the VQ ratio becomes 0. With 0 for ventilation, no matter what blood flow you have, you're going to have a VQ ratio of 0. This means that venous blood is going to enter the arterial system of the body without being oxygenated because it never passed through ventilated segments of the lung, and this in turn is going to cause hypoxemia. So to understand what happens in shunting to cause hypoxemia with a high AA gradient, let's look at this cartoon I've placed on the slide here. So this is part of the bronchial tree, which splits into two alveoli, one here on the left and one on the right. And both of those alveoli have an associated pulmonary capillary that allows blood to flow past them. So venous blood comes over here. It's about 70% saturated with oxygen. It leaves at 100% saturated. Same thing happens on the other side. And so when the two streams mix, we get a normal oxygen saturation of 100%. Now let's imagine what happens if we shut off airflow and ventilation to the alveolus on the left side of the screen. That's going to lead to a VQ ratio of 0 on the left side of the screen. So what's this going to mean overall? Well, on the right side of the screen, we have blood coming in at 70%, just like usual from the venous system, and it leaves fully saturated at 100%. That's fine. But over on the other side of the screen, we have blood coming in at 70% saturated, and it leaves at 70% saturated because it hasn't passed any ventilated portions of the lung where it can pick up oxygen. So when these two streams meet, that's going to lead to the development of hypoxemia, and this is going to be hypoxemia with an increased AA gradient. And then a special thing about shunting I want to show you is that if you administer 100% oxygen to the patient to try and resolve the hypoxemia, what's that going to do? Well, on the right side, blood was already being 100% saturated, so nothing's going to change. It can't be more saturated than 100%. And on the other side of the screen, we've got blood that's bypassing the lungs and not getting any air at all. So it doesn't matter that you're giving 100% oxygen. None of it's reaching the left side of the screen. So that blood's still going to leave at 70% saturated. When the two streams mix, you're still going to have hypoxemia. So this is a huge and critical point to understand about shunting. Shunting does not resolve when you administer oxygen for the reasons I just showed on this slide. So some key points about shunting are shown on this slide. As I said before, in shunting, there's no ventilation to a portion of the lung. This leads to venous blood that has not been able to pick up oxygen mixing with oxygenated blood, and that causes hypoxemia. The VQ ratio in affected portions of the lung by shunting is 0, and this leads to hypoxemia with a poor response to oxygen. And the poor response to oxygen is super high yield to understand. This is the only cause of hypoxemia that has a poor response to oxygen. The PaCO2 in shunting may be normal. In general, shunting does not change PaCO2. The most important factor for the PaCO2 is ventilation, whether you're hyper or hypoventilating. So if you're ventilating normally, the PaCO2 should be normal. It is true, however, that if you develop 50% shunt, meaning half the lungs are shunted blood, this is very unusual. But in this setting, the PaCO2 can start to rise because you're mixing venous blood with oxygenated blood for about half of the blood in the arterial system. But outside of this one very unusual circumstance, PaCO2 is usually normal in shunting unless there is concomitant hypoventilation. And then it's normal to have a small shunt of about 2 to 3% of the cardiac output. That's what causes that normal AA gradient of 10 to 15 that we talked about earlier because of shunting from the trapezius and bronchial veins. And many lung disorders have some degree of shunting, but a very important pathologic cause of shunting to know about is ARDS, which is the acute respiratory distress syndrome. I talk about ARDS in other videos, but it is a classic cause of shunting, and there are many patients with ARDS who don't improve with oxygenation. That's because they are shunting. So VQ mismatch refers to a ventilation to perfusion ratio that is less than 1. Anytime this happens, you have reduced ventilation relative to perfusion. This means that perfusion, in other words, blood flow, is being wasted. It's going to parts of the lung where there's not enough oxygen present, and this is going to lead to hypoxemia. And basically, shunting, which we already talked about, is an extreme version of VQ mismatch where VQ equals 0. But in general, in pulmonary physiology, we don't refer to shunting as a VQ mismatch. When we say VQ mismatch is occurring, we mean the things I've listed right here. Basically, reduced ventilation relative to perfusion, but you still have some ventilation. The ventilation is not 0 like it is in shunt. And so as I already said, when there's VQ mismatch, you will get hypoxemia with an increased AA gradient. And what distinguishes VQ mismatch from shunt, where the VQ ratio is 0, is that VQ mismatch leads to hypoxemia that does improve with oxygen, and that distinguishes it from shunt. And there are many disorders that have some degree of VQ mismatching, but the classic cause is pulmonary embolism. When patients have a pulmonary embolism and they develop hypoxemia, that hypoxemia is associated with a high AA gradient, and the mechanism is VQ mismatch. And I explain this in more detail in the video on pulmonary embolism. So to understand VQ mismatch, let's go back to this little cartoon, which we saw before when we were talking about shunting. So once again, we have two alveoli, and the one on the right is being perfused normally. So venous blood comes in at 70% oxygen saturated, and it leaves at 100% saturated. But in the alveolus on the left, you have some limitation to ventilation so that ventilation is decreased. It's not zero like in shunting, but it's decreased compared to the normal side. So over here on the left side of the screen, where the VQ ratio is less than 1 and we have VQ mismatch, venous blood comes in at 70%, but it doesn't get fully oxygenated. It only gets partially oxygenated to, say, 80%. And so then when the 80% blood mixes with the 100% blood, what you get is hypoxemia due to VQ mismatch. But just like we did before with shunting, let's think about what happens if you give this patient 100% oxygen. That's going to fill both alveoli, the one on the left and the one on the right, with 100% oxygen. The one on the right side of the screen is already fully oxygenating blood, so giving 100% oxygen to this alveolus doesn't change anything. But over on the left side of the screen, we weren't fully oxygenating the blood, so if we increase the amount of oxygen in this limited alveolus, which has VQ mismatch, we will raise the oxygenation on the left side of the screen. Maybe it'll go from 80 to, let's say, 90, or maybe if we're lucky, even up to 100. And so the point here is that because you have some ventilation in this dysfunctional alveolus on the left, you can add 100% oxygen and that will improve the hypoxemia. And that did not happen in shunting because in shunting there was no ventilation over here on the left. And even when we tried to fill the lungs with 100% oxygen, it didn't do anything to the alveolus that was suffering from shunting. Okay, so there you have it. Now we've talked about hypoxemia with a high AA gradient and the three underlying mechanisms of that problem, which are diffusion limitation, shunting, and VQ mismatch. Now I want to make a side point about carbon dioxide because this can be very helpful when you're trying to understand why a patient has hypoxemia. So in the video on dead space, I talk about causes of hypercapnia, meaning an increased arterial concentration of CO2. And there are three ways this can happen. The most important one is hypoventilation. If you underventilate the lungs, CO2 will not get blown off and it will be retained in the arterial blood and the CO2 level will go up. You can also get hypercapnia from increased dead space or increased carbon dioxide production by metabolism, but these two things right here are really less important than ventilation because if you can increase your ventilatory rate, then these things will not lead to hypercapnia. The only way you get hypercapnia is if you have some degree of hypoventilation, even if these things are going on. Make sure you understand that. Anytime you see elevated carbon dioxide in the arterial blood, there is hypoventilation by definition. Could be these things, maybe they're here, maybe they're not, but there's definitely hypoventilation. And so earlier we talked about how hypoventilation can lead to hypoxemia with a normal AA gradient. Well, you should know that hypoventilation can also lead to an increase in the alveolar concentration of CO2. So if you think the diagnosis for a particular patient is hypoventilation, you need to see hypoxemia with a normal AA gradient, and you also need to see an elevated PaCO2 because this will always be present when there's hypoventilation. And then also, if you see hypoxemia with a high AA gradient from one of those causes we talked about, like shunting or VQ mismatch, those are not associated with a rise in CO2 unless there's concomitant hypoventilation. But in and of themselves, those mechanisms for hypoxemia with a high AA gradient do not cause a rise in the CO2 level. So I want you to remember that. Anytime you see the CO2 level, it's telling you whether ventilation is adequate or not. And the only thing that will raise the CO2 level is hypoventilation. So down at the bottom of the slide, I've written the key points to remember about hypoventilation. It's a very common cause of hypoxemia and hypercapnia. It will lead to a low PaO2 with a normal AA gradient. And anytime the PO2 is low, the O2 sat will get low. And as we just talked about, there will be hypercapnia anytime there is hypoxemia from hypoventilation. So on this table, I've summarized some of the key points to remember about mechanisms of hypoxemia. So remember, the definition of hypoxemia is a low PaO2. So that's always going to be present when you have hypoxemia, no matter what the AA gradient is. If the AA gradient is normal, then the alveolar O2 is also going to be decreased. However, if there's a high AA gradient, then the alveolar O2 is either normal or increased, but it's not decreased. And then, of course, a normal AA gradient is 10 to 15. The causes of hypoxemia with a normal AA gradient, remember, are basically high altitude and hypoventilation. And the way you distinguish these two is that in hypoventilation, again, a very important point, there's always a high PaCO2. At high altitude, the problem is a decrease in the inspired oxygen content. And then we went through all three of these mechanisms of hypoxemia with a high AA gradient. And then this slide summarizes key points about the mechanisms of hypoxemia associated with a high AA gradient. So these are the three causes of hypoxemia with a high AA gradient. They're all associated with a decrease in PaO2 because that's the definition of hypoxemia. In and of themselves, none of these lead to a change in the PaCO2 unless there's concomitant hypoventilation. And then the big way you distinguish these three from one another is what happens when you give 100% oxygen to the patient. That will not affect shunt. It's super high yield to remember this. If you see a case of a patient with hypoxemia with a high A gradient, doesn't get better with oxygen, that's a shunt. Diffusion limitation is usually identified by history and chest x-ray and other findings that show there's fibrosis or something limiting diffusion in the lungs. And then VQ mismatch is usually the mechanism that's assumed when you know it's not shunting and you know it's not diffusion limitation. Okay, now that we've talked about all that, let me give you some tips for how to approach questions when they ask you about the mechanism of hypoxemia. This is something that can be very frustrating as a medical student, so on this slide I've got some tips for you. So first of all, if they give you all the numbers, you may be able to calculate the AA gradient. To calculate the AA gradient, you need the arterial oxygen content, the inspired oxygen content, and the arterial CO2 content. Once you have those things, you can use this equation right here, plug in the inspired oxygen content here. It will be 150 if the patient is breathing room air at sea level, and then plug in the PaCO2 here, and that will give you the PaO2, the big A, and then you can calculate the AA gradient. Now, many times they won't tell you the AA gradient, but they'll still ask for a mechanism of hypoxemia. And in those cases, they want you to infer whether the AA gradient is normal or not based on evidence in the question stem. So for the AA gradient to be normal, there has to be an absence of lung pathology. So if they tell you the lungs are filled with fibrous tissue or fluid or something like that, then there's not going to be a normal AA gradient. Also, if they tell you that the patient is at high altitude, you just need to know that that's going to lead to hypoxemia with a normal AA gradient. And then they may also give you evidence of obvious hypoventilation, like a patient with a very low respiratory rate, or a high CO2 level, or a patient who's been given heavy sedation. These are all clues that the patient is hypoventilating as a cause of their hypoxemia. And then things in the question stem that suggest a high AA gradient are, first of all, hypoxemia despite supplemental oxygen. So if the patient is receiving a lot of oxygen and they're still hypoxemic, they have to have a high AA gradient. Over here, I've showed you the PiO2 for a bunch of different forms of supplemental oxygen. And you can see that compared to 150, which is the PiO2 on room air at sea level, all the supplemental oxygen devices shown here give a much, much higher PiO2. So if this number gets enormous, then that means that this number is going to get enormous, and the AA gradient then is going to be very high. So anytime they tell you that the patient's on supplemental oxygen, but they're still hypoxemic, you have to know that that almost always means there's a very high AA gradient. The other thing that can suggest a high AA gradient is evidence of definitive lung pathology. So if they tell you the lungs are filled with fluid or pus or fibrous tissue, they're telling you that this patient has lung pathology, and that's what can lead to hypoxemia with a high AA gradient. And then lastly, this is super high yield. I can't say this enough. If they describe a patient who does not improve with oxygen supplementation, that almost always means a shunt. Now, one thing to know about sort of real life outside the boards clinical medicine is that hypoxemia in many patients, especially hospitalized patients, is from multiple mechanisms. There have been lots of studies on this, but patients who have COPD, pneumonia, or pulmonary edema, they can have VQ mismatch and shunting and diffusion limitation and multiple things going on at once. For example, pneumonia has been well described as causing both VQ mismatch in some parts of the lung and also some shunting. So unfortunately, you can't just memorize that for a given disease, this is the mechanism of hypoxemia. But there are a couple examples that I think are worth knowing, and these are the ones I've listed here. So if there's an intracardiac shunt, like a VSD or an ASD in the heart, that's going to lead to hypoxemia with a pure shunt mechanism. Blood is passing from the right heart to the left heart without going through the lungs. That's a shunt. Oxygen is not going to help. If they describe a child, for example, who inhales a foreign body and it blocks off one of their bronchi, that's going to lead to zero ventilation over in portions of the lung, and the VQ ratio over there is going to become zero. So that's going to create pure shunt physiology in one section of the lung. ARDS, which I talk about in another video, the adult respiratory distress syndrome, is a classic cause of significant shunting. Many patients who have that condition, one of the challenges in treating them is that their oxygen doesn't improve with extra oxygenation. And then I already mentioned this, but in pulmonary embolism, the cause of hypoxemia is VQ mismatch. And I go through this in much more detail in the video on PE. And that concludes our module on hypoxemia.